Thanks, and welcome to everyone. For those of y'all that I don't know, I am Jeff Rouse. I'm a prosthodontist down in San Antonio, Texas. I ran a general practice for about 14 years, family practice actually. And so I've got experience in both running a family practice and a prosthodontic practice. Giving you my email address, and welcome to Spear. We're going to share some of the history of Spear as we walk through. As we might expect, Jerry, the Zoom froze up on me on the
Now it goes.
first slide. We're going to walk through some of the history of Spear and some of the important points that come with treatment planning. And then we're going to build towards Airway, because Airway honestly is, it's not a sleep appliance anymore. I make very few of those. It's actually, how do you fix the anatomic irregularity that the patient presents? And it weaves its way perfectly into what we've done forever at Spear. So the first thing is, in 1986, Frank Spear introduced the idea of facially generated treatment planning. And it works off a very simple concept of dentures. So he didn't magically come up with ideas. He built on what had been around forever and ever, which is the denture idea of, we always set the maxillary teeth first, and then we work our way to the mandibular teeth, and we start with the central incisors. And it makes sense now, and everyone would go, well, of course we do it that way. But at the time, the world was a world built around occlusion, which means we built everything off the lower arch. We set the curvus Fium Kerper-Wilson on the lower arch, and then we fixated the teeth, the maxillary teeth to it, or warped them in order to actually allow it to work correctly. But Frank finally said, you know, that doesn't make sense at all. We really need to set the central incisor. So a case that makes the point about how he was thinking at the time, and then how we've evolved, is this particular gentleman that he treated years ago. When he came in, he had wear on his anterior teeth, wanted the wear addressed. He had had a lower anterior tooth removed previously, and he's still wearing straight down on top of them. When Frank used the FGTP concept, he said, I need to set the incisal edge of the central incisor first. And in fact, I think along the line of the posterior occlusal plane would be a perfect place for it. So right there would be good for the centrals, laterals, and cuspids. He went to his orthodontist, Vince Kokich Sr., and said, I need you to intrude the teeth so that I can actually restore the teeth. And so they put together a plan to actually do exactly that. So the teeth were intruded, composite was added in order to finalize the case. And then they finished the case with ceramic on top. And that's it. So 4 veneers and the case is done. Beautiful smile, followed the plan exactly the way that they had outlined it. That plan was built from aesthetics through function, structure, and biology. Now, that's the way all of our cases are planned. We obviously don't put veneers on before we treat biology and make things healthy, but we always think in terms of where do these incisal edge of the central incisor belong. Look at tooth position, then we evaluate gingival levels. We'll go to function, which was joint issues, muscle issues, make sure those are stable so we don't want things moving around. From a structural standpoint, we try to figure out what kind of restoration and do we have enough structure to actually work with. And finally, biology is disease. That's the FGTP concept of treatment planning that was established in 1986 and has worked beautifully for years and years and years. However, today there's somewhat of a paradigm shift, which means for us at Spear that we're not only considering the vertical dimension of the central incisors, because that drawing is a very two-dimensional view. We're actually considering it in 3D. We're looking at the transverse and the AP dimension of the central incisor. So we're recognizing that, in fact, there's more to it than simply drawing in a two-dimensional perspective and then working within the confines of what we've been given. That's where the Airway comes in. You see, now, instead of starting treatment plans with aesthetics, function, structure, biology, we begin every treatment plan by asking the question, does the patient have an airway problem? And said more specifically, it's not so much about do they have apnea, or do they have upper airway resistance? But really, do they have a skeletal or dentoalveolar problem that could be caused by an airway issue and previously is in growth and development, or in fact, because they have it, they're actually having more difficulty breathing at this point in time. So airway is not about apnea. It's about anatomy. Get the anatomy where it's supposed to be. Now, here's the interesting thing. The way that Vince and Frank worked, they said, we have to get overjet on this case, even with the intrusion and the orthodontics we're going to do. How do we go about getting intrusion? Well, they took out another tooth. That's how they solved the problem. Did a little Kessling setup to verify they could actually make it happen. Today, what we would say is start with the airway. And when we evaluate the airway first, we realize there is a structural and a dentoalveolar or skeletal, and a dentoalveolar problem in this case that needs to be resolved. If we were to take it back to our denture example, we would say we've been given too small of wax rims. We're not working with these. We're not going to try to omit putting teeth into the denture to solve our problems. We're just going to add wax and put the teeth where they're supposed to be, rather than trying to just find ways to camouflage obvious airway anatomic problems. So our denture example now is no longer about setting the central incisors, because really dentures, as you know, start before that. They start by figuring out where the wax belongs in the wax rim before you would ever consider setting a tooth. And if you looked in on a case and said, it really is deficient in the max in supporting the lip or in the transverse, you now say, well, that's an airway issue. And the other thing that you'll all be able to relate to is you would never go in on a case like this and begin setting teeth on that wax rim. Every single one of you would get out more base plate wax, add the wax until you got it exactly right. That's all we're asking at Spear for you to do, is make the wax rim correct before you begin. Now, we're not suggesting that everyone is going to jump on to the perfect treatment plan. What we are suggesting is that you need to at least be aware of the problem, because patients suffer when we miss it. And I'm going to go through 3 patients or patient types that actually really can be damaged if we as dentists happen to miss this. So we always say that we shouldn't set the teeth before we evaluate the wax rim. Pretty straightforward. The wax rim is our skeleton and our dentoalveolar housing, in particular in the maxilla. Get the maxilla correct before we begin. All right, so who is impacted by the airway dysfunction? Probably the most damaged are children. And so once again, at Spear, when we started talking airway back in 2016, we brought in children, which we'd never really talked about at Spear, and started really trying to develop a protocol on how to intervene early in these children to make them healthy. Because in fact, they're damaged if they have airway issues in one of 3 ways, if not all 3 of the ways. The first way that they could be damaged is neurocognitively. And so neurocognitive, we're going to look at literature on ADHD, but we're also talking intelligence here, just straightforward IQ points. The premier study in looking at the connection between ADHD and airway is this study from Karen Bonnick. Now, there are a number of studies that are more current and as big and as much power in the statistics of it. This happens to be the classic article that if you're having a discussion that you're going to reference with physicians. So I wanted to provide it for you. The first thing that Bonnick did was go over to England and look at their medical data for children. And they followed these kids over a long period of time in their national health system. And they were asking the parents 3 things. Does your child's mouth breathe, snore, or have witnessed apneic events while they are asleep? They asked those questions at 6 months, 12 months, 18 months, 24 months. 4 years and 7 years. So they followed up for quite some time. At the 4 and 7 year mark, they asked questions related to attention deficit and hyperactivity. There were over 11,000 kids, and as I said, they followed them for 7 years. Actually, the study in a moment will see the 15-year follow-up that they did not too long ago, and it's more of an orthodontic study we'll look at. What was the most significant or some of the significant results of the study? Well, one of them is the worse the disease, the worse the problem. And so it's not actually, I should say that differently. It's not the worse the problem, it's the highest percentage of children that had the issue. Problem is the same. I mean, if you get ADHD, you have the same problems no matter how it comes about. It's just that kids with witnessed apneic events tended in this study to have higher levels of ADHD. Now, that's not necessarily true in the more current prospective types of studies that they're doing. But in this particular study, they said kids with witnessed apneic events tend to be at higher risk. Some other important pieces of information are if they are having symptoms young, 6 months to 18 months, the risk of having ADHD is about a coin flip's chance. So 40 to 50% of the time at 7 years, they're going to have attention deficit. She had these things called clusters, and I'm going to go through 2 of them. There are many of them. You ought to, I think it's a free article on the internet from Pediatrics in 2012. One of the clusters she called worst case, which is that the sleep disturbed breathing problem peaked by the time they were 30 months old and went away. But in fact, they had attention deficit at a high level at 7 years old, and it happened to be hyperactivity, conduct, and peer difficulties. There are, however, another group of kids that went along just fine until they were 4 years old when their tonsils and adenoids finally enlarged. That's when they started noticing symptoms. Between 4 and 7, those kids went from no ADHD to all of a sudden having it. So I like to counter the comment from many physicians and even orthodontists that children will grow out of it by showing them this particular study and saying, in fact, no, they actually grew into the problem many times. Second study looks at academic performance in children, and they looked at it over an 8-year period of time. They started following these kids. They found that if they had a history of sleep disturbed breathing issues from early childhood, just like Bonnick's young group, that in fact they were worse academically at the age of 8 in many ways. And this study and others have followed up on it and actually found it could be upwards of a 10-point IQ reduction. So that's neurocognitive, attention deficit, intelligence. What about systemic issues? Well, a number of studies, once again, are coming out with all kinds of different I guess an easiest way to say it is pretty much if you have a medical issue related to apnea as an adult, kids can get it as well. What I found interesting in this one study, and the reason for including it, is that if you have apnea as a kid, it makes you more prone to have hypertension as an adult. So it sets you up for that by simply having apnea as a child. The last one may be the worst of all of them, because if craniofacially you change and get narrower and more deficient in an AP dimension because of the breathing problems young, that sets you up to have the problem long term. So what we're really looking at in the dental office is deviations from normal, and we can pick this up very quickly. The physician has to wait around for symptoms to occur. And in fact, we can find it at our first visit, just looking from deviations from normal. The second is those deviations will occur really young, 3, 4 at the latest. You'll be able to figure it out that they're not on a good growth path. And you can and should start intervening at that moment in time. And that early intervention can actually direct the growth and improve the growth, and more importantly, can improve both the systemic and neurocognitive health of the child. So let's look at some of the more current literature or some of the literature on points of obstructing, directing growth, and then sort of move forward from 2010 to more current literature. In this particular study, they looked at 114 kids from 3 to 12 years old, and they had big tonsils and or large adenoids. And so they scoped them and evaluated the impact of that and how much obstruction was being caused. If the tonsils and the adenoids were obstructed points, they noted that. If it was adenoids only, tonsils only, and then they had them, but they weren't obstructing at all, they made a note of that group and divided everyone up. The majority of kids fell into the both category. What did they find? They found higher rates of class 2 relationships in the both category, where both tonsils and adenoids were blocking. That makes sense if you think about it. If you've got a significant amount of obstruction, the odds of you opening your mouth and breathing through your mouth all day long would increase dramatically. And because of that mouth breathing, you're going to be more prone to growing in a vertical direction. We, in fact, call it an adenoid facial type because people will breathe through their mouth. That narrows the arches, decreases the eruption of the maxilla, creates that vertical growth pattern that we see in some of our patients. The other thing they said is if the tonsils alone are the obstructive point, you end up being more class 3. And so a moment of clarification here, class 3 actually is maxillary deficient in almost every case. Now, we were trained that it's a mandibular issue, but remember, we're trained by Edward Angle. Edward Angle was in the early 1900s. What Angle's mistake was is he assumed the maxillary molar was always in the proper location, and therefore all you had to do is compare where the mandible comes in. But in fact, what we recognize today is you can be extremely retrusive in the maxilla, and it's could be, and in fact is in this particular case, because of those large tonsils. All right, so that's children and the impact on them. The next group is called young fit females. So the young fit females would be fit meaning obesity is not a player. Obesity would be apnea. Young females, the interesting thing about young female is progesterone. Progesterone is a pharyngeal dilator and also creates a drive to breathe, which means women are at a hormonal advantage over men in order to not have apnea until they are postmenopausal. And if you watch the statistics, 60-year-old women and 60-year-old men almost have equivalent numbers of people having apnea at that point. But before that, women hardly have apnea at all. Once again, it's hormonal. Now, guys can fit into this category, by the way. I call it young fit females, but the name of the category really is upper airway resistance syndrome. Guys can be that. Typically, guys that are in this particular category are tone, which means the airway, they react very well to the airway. And they, as the airway becomes compromised, the tone of the airway takes over and they can fix the problem. So think thin people, runners, or people that even you could throw into this, people that play certain wind instruments. Trombone would be one that they learn circular breathing. In this particular category or patient, as we're proposing it today or presenting it today, they have stressful breathing rather than apnea events. And so if they've gone to a sleep physician and if they've had a study run, it will come back as normal. Not obese, hormonal advantage. By the way, the people you see that fit perfectly into this category are your TMD patients, your myofascial pain patients. They are airway patients. They're sympathetically active. And in fact, this study exposes that. It looked at UARS, upper airway resistance patients, that they also called TMD patients, and they went in and got a diagnosis. Then they looked at the resistance to breathing all day long and found it was 3 times higher in this group than in normal groups, which means when they wake up in the morning, the small jaws and narrow noses and such don't go away. So this is a 24/7 problem. That's why I said airway is different than sleep. Sleep is a moment in time, but airway is a full-time issue. Now, in this group, you get the patients that come in and make splints on them. And in fact, this was a TMD patients diagnosed with UARS. What were some of the commonalities? A lot of them had headaches. That's the reason that you would make them the splint. Bunches of them will complain of bruxism as well. Same deal. But I found the most interesting thing on the list that they were doing is that 92% of them can't breathe through their nose. You can't be healthy and not breathe through your nose. So our idea when we're talking about expanding patients and expanding children and doing all this dentistry in the upper arch, the maxilla, is not necessarily to get to the teeth. The teeth are a byproduct of the action that we're going to do. It really is to fix the nasal cavity, expanding the upper arch, expanding the nasal volume, correcting the deviations of the septums by expansion. That's the key to the whole thing. Get them to breathe through their nose. And in fact, if you look at this subset, the young, fit females, micrognathy was more prevalent in women with this partial airway obstruction than even apnea. So the patient that fits in that group needs orthodontic intervention. Our last group is old fat men. And once again, you don't have to be a man or old or anything like it in order to fit into the group, but you have to have apnea. And typically it is obstructive in nature. Something's in the way. Obesity, not only do you grow out, but you grow in. And the first thing to gain weight in the body is the tongue. So obesity does play a role, but so does a lack of tone. As we age, we also lose tone, which is the thing that was protective for men before if they were the UARS patient. Okay. I wrote an article years ago about apnea, bruxism, and reflux all being related to one another because it was the thing I kept seeing in my patients over and over again. So let's go through those couple of items just so you have a clear vision. First is bruxism, and just, I don't know about you, but I learned a bunch of things that I later on found out probably weren't all that true. Like you brux really, really hard when you're asleep. Well, that doesn't happen because if it did, then people would be breaking their crowns in the middle of the night. And they don't. No one breaks crowns and teeth while they're asleep. It just doesn't happen. It's because the bruxing activity at night doesn't create huge forces. That occurs during the day. And also you break things when you eat. That occurs during the day when you're awake as well. The interesting thing about nighttime bruxism is it's weak. It's kind of like the amount of force you have on your teeth when you swallow. But it's dry because you're breathing through your mouth, you're creating reflux, so you actually wear the teeth down pretty significantly. The other part that I've always found interesting is trying to ask the question, why? Why would you do that to yourself? And I was taught it was about trying to work out a second molar interference, which I laugh at when I think of how gullible I was for so many years. Really, it's about the body trying to protect itself. Now, is this every situation in every case? No, obviously not. But for the vast majority of patients and the vast majority of events, I believe it's trying to fight off a negative pressure event. And there are two negative pressure events that occur. One is the airway closing down, so preventing you from having apnea. And the second is reflux coming up. You create a bunch of negative pressure, reflux comes up, you got to do something. You've just altered the pH so much, you have to be able to swallow, and you don't have any saliva, which means you got to generate it. So how come we don't know more about that? Well, Jerry Simmons is a sleep physician down in Houston, and he uses a very sophisticated way of monitoring the inspiratory flow limitations of breathing rather than the huge apneas, which most labs do. They just count big old events, and he was looking at small airway events that create negative pressure. What he says is because we brux, we minimize the degree of the obstructive respiration, making it tough for him to diagnose. So airway begins to close down, body reacts, airway opens up. They don't, in the sleep lab, mark it down as an event at all. Second thing he says is if you don't monitor little events, inspiratory flow limited breathing events, the increase in the effort just before the bruxing activity isn't being recognized at all. And therefore, you don't associate it with, oh, they were about to have an obstructive event and they fixed it. You just don't see it at all. So we would know this if we monitored them looking for smaller events, which ain't going to happen because sleep physicians don't get paid for monitoring small events. Simmons happens to have an interest in trying to find a connection to bruxism. That's why he does it. You could work the problem backwards, though, right? If I believe that the airway and its shutting down, its negative pressure is the culprit behind this, then if I fix it, then the bruxing should get better. And in fact, there's studies that show exactly that. Using CPAP, mandibular advancement appliances, taking out tonsils and adenoids, expanding, all those things. All right, next is reflux. And once again, a point of clarification. I learned everything was GERD, and GERD was stuff percolating out of the stomach and giving you ulcers and such. Now that exists, but in fact, there's another one type of reflux that's even more predominant. In fact, it's more predominant in women than in men. And it's called respiratory reflux or laryngeal pharyngeal reflux, LPR. Okay, so let's go through the difference between the two. The first is esophageal reflux or GERD. Feels like a heartburn or like a heartburn, heart attack even. I mean, it really can be intense pain. Indigestion, another word that people will use. If you have a patient that has those symptoms, or you see erosion on the teeth and they have those symptoms, then you need to get them to a GI doc. Let them scope them, ward off, anything before it becomes a problem with Barrett's esophagus, esophageal carcinoma. Here's my problem. I see so many people that have erosion on their teeth, and I kept referring them to GI docs, and they would get scoped and nothing. We get a report back and it'd say everything's fine, no problem. But in fact, I know there was a problem. And so it took years, but we finally figured out what was going on, or at least I did. Like I became aware of it. It's a thing called laryngeal pharyngeal reflux, LPR. Totally different symptoms. Symptoms here are not this excruciating heart attack like heartburn. In fact, it's chronic throat clearing, postnasal drip. Feels like you just got this big lump of snot in the back of your throat when you don't. Hoarse in the morning, difficulty swallowing certain foods, chicken and bread tend to be the hardest ones to swallow. You don't need many episodes in a day to cause it to be a problem. And the difference here is that it gets up above the upper esophageal sphincter. The enzymes cause the symptoms to occur. The acid causes the damage, and the person to refer this to is in the ENT rather than the GI doc. All right, so let's look at the relationship between bruxing and reflux. 2 studies. First study, 10 patients that bruxed their teeth every night, 10 patients that didn't. They were monitoring them for oral pharyngeal pH and bruxism. What did they find? They found that when the pH dropped to below 5, in that 4 range, maybe there was one person that got a little lower than that. When that happened, then the bruxing would take off. Here's the interesting part. Only the people that brux allowed the pH to drop. All the people that didn't brux all night long never allowed the pH to drop into those levels. So they grabbed a bunch of people that never bruxed at all, and they said, you know what, if we put a tube down your throat and inject hydrochloric acid in the middle of the night, it will simulate what this other group is actually feeling. So somehow they came up with 12 volunteers to do that. And sure enough, when they injected the hydrochloric acid, 20 minutes later, the pH dropped and the people start grinding their teeth. At the end of the grinding, what do? They swallowed and they buffered and they stopped grinding. So why would you do it? Well, in order to buffer, in order to be able to move along with life. And in fact, the only person that didn't grind their teeth and swallow during the night was a person that complained of heartburn in the morning. All the rest, no complaints at all. Last part in this section is malocclusion, and it really is a focus on the maxilla. My plea is that we begin focusing more and more on the maxilla than the mandible, even though your training was about the mandible, and so was mine. It was occlusally based. Really, we need to be looking at the maxilla as a whole, because if you look at the maxilla and it is constricted, that person is having more difficulty breathing. And if you talk to them about making them healthier, you actually can do more dentistry, because people are interested in that much more so than aesthetics, or for sure more than function. And that allows you to do what? It allows you to use dentistry to promote health. We could, this problem that you got could be related to the maxilla. If we do this, that problem may go away. And oh, by the way, you'll have a better looking smile and better function. Problem we got to get out of our head is that we keep thinking of the maxilla as this, dental aesthetics, and it's not, it's this. I mean, it's, yes, at the end, you got some teeth in there and you can make the smile pretty, but really it's a bigger structure. It involves the entire nasal cavity. So let me show you how I go about evaluating the maxilla when I'm looking at a patient, say in the hygiene operatory. First thing I do is when I greet them, they smile, and I'm looking at the buccal cord or excess space, so negative space. Is it too much or is it just right? By the way, I was going to say too little. Too little doesn't happen unless a dentist puts veneers on the teeth or an orthodontist torques the teeth out too much. So very rare that you actually see that. So is it too little or is it just right? Sort of the Goldilocks principle. If after I've looked at them and I go, okay, buccal corridors are fine, I look at the vertical display and see if they show gums ear to ear. And if they do, then I start thinking, man, that could be an airway problem, because those kids that Karen Bonnick looked at up to the age of 7, those kids are 15 at the time of this particular study. And what they did at the study is they got a bunch of them that had sleep disturbed breathing issues at some point in time since birth, and a bunch that were asymptomatic. And they did laser facial scanning. They created a composite face that they built up, said, okay, that's what it looks like. And the laser facial scanning on the face that ended up having airway problems was narrower, more retrognathic. Most importantly, though, the nose was narrower and it was set back, which means the maxilla was narrower and it was set back as well, because the nose is dictated and its size and shape is dictated in many ways by the maxilla. When you look at the group that was breathing well since birth, they look different. Their mandible's out farther, their nose is wider, their forehead is more prominent. Lots of different changes occur when you can breathe. By the way, when you look at a patient that ends up having vertical issues, you pretty much are always looking at an airway patient, but more importantly, you're almost always looking at a joint patient as well. So Jim McKee, I know, is coming up with a webinar. He's going to describe those for you. Third thing that I look at in the maxilla is the same as the first, it's just the presentation. The first one is they smile at me, and this one I'm actually looking at the tooth-to-tooth interdigitation in order to figure it out. So are they edge to edge? Are they in crossbite? Or do they give the illusion of class 1, but in fact the lower teeth are tipped in pretty dramatically in order to make that happen? Now that's important because the intermolar and interpremolar distance sets you up for having apnea. A couple of studies out of Brazil, these are ENT groups that developed this. They measured inner premolar and intermolar width on a cone beam and related that to whether or not the patient had apnea. And sure enough, your risk goes up if you're narrow in the maxilla. They then wanted to figure out where the narrowness would lie and what impact it had. So they did the same measurements of width again, but they also did DISE, drug-induced sleep endoscopy, so they could watch the obstructive points. What did they find? They found that if the inner premolar distance or intermolar distance are narrow, that in fact the patient is significantly more likely to have apnea, and that apnea is going to be a blockage at the base of the tongue. The third item on this list tells you the next part I want, which is if you're narrow in the molar region, you're going to have multiple levels of obstruction. So soft palate, base of tongue, all those. The middle one's probably the most important, which is if you're narrow in the molars and the soft palate is part of the collapse, it will collapse circumferentially, which happens to be the most difficult one to take care of. So the hardest obstruction to deal with, especially from a surgical perspective for ENTs, is caused by your maxilla being too small. In fact, all this is. The solution is make it wider. And sure enough, this group of ENTs worked, and were all surgeons that worked with bone as well. And that was their conclusion of the article. When you see the molars and premolars too narrow, you need to expand everything, even if it requires a surgical intervention strategy. Fourth one is I look at AP position in the front, and typically people that are having airway issues don't push the maxilla far enough forward, so you have a limited overjet, if not an underbite in the front of the mouth. A fellow named Dempsey gave us some measurements we can work with. He said that actually a bunch of stuff that I agree with. One is that if the maxilla is decreased, that he found that to be the case in his apnea patients. Apnea patients equal smaller maxillas. He also said this bimax protrusion can fool you. Molar to molar relationship is class 1, but in fact, it's all set back in the head too far. He gave us a number. He said from A point, which is the point right below your nose, to porion vertical. So he just drew a vertical line there. He said if that's 97 millimeters or less, that you're 5 to 7 times more likely to have apnea if you're non-obese, and 3 times more likely if you are obese. So while obesity is a player, craniofacial anatomy is a much bigger player. And he highlighted again, maxilla is the problem, not the mandible. The mandible can be a player, but the maxilla is your bigger problem because it's connected to the nasal cavity. All right. So in conclusion, I know we got a handful of questions that we're going to answer. Today, what I keep hearing from people is my patient has an airway problem, and the next line out of their mouth is their sleep study showed me they have moderate sleep apnea. That's not an airway problem. That's a sleep problem. That's managing your airway while you're asleep. What you want to say is my patient has an airway problem, and then make a list of what the problem is. They've got it, and it's always anatomy. They've got a constricted maxilla, deviated septum, a tongue tie, big tonsils and adenoids, whatever the case may be. Airway problems are anatomic problems. They are not sleep problems. And if we can all agree on that and start focusing more on the anatomy, then we as dentists can actually deal with that. If we're focused on the AHI, then that's a medical model, and medical model is not something that I personally want to get involved in. I just want to do dentistry. So for me, anatomy is absolutely the key, and that's how we teach it in the airway course. So in our workshops out at Spear, I always recommend people start with facially generated treatment planning, although there is a conduit that you can come in through airway. But if you start with FGTP, like in the first case that we did, you figure out how we actually treatment plan from the central incisor. And then you build on that concept by adding in the 3-dimensional perspective when you finally get to airway. Finally, last weekend, when you get all the way through, we've got a new course where we do advanced treatment planning. And that ties together those two concepts beautifully, where you make decisions based on the health of your patient, aesthetics, and function of the patient. And then we do multiple cases where we go, okay, well, what if your patient says no? And we go in and try to start providing answers to those as well. So I know they're going to be giving you in the chat section some information about SPEAR that you can talk to some people about, but we would welcome you to get out to SPEAR Education. And speareducation.com is the website that you can check. So let me stop the share and answer some questions. The first one is, would it be possible to provide a list of the studies, so many patients who don't believe me, kids, women, young men are good with usually. The studies, actually, we don't have it's actually something I'm working on. Eventually we'll create it. We're going to create a library, but for example, if you come to the Airway workshop, I have 2 days full of basically the studies associated with the things you're talking about. And then you can just Google those Google them and get the free ones, or you can go to the ADA library and they actually provide it as well. Probably the list that you've given me, there are a couple of textbooks. Let's see. I was looking around. Probably the easiest textbook to go. It's not even a textbook. The easiest book is called Sleep Interrupted. Sleep Interrupted by Stephen Park, Dr. Stephen Park. He's an ENT. And the beauty about the book is that it's sort of how he evolved into realizing that the patients he was seeing were airway patients. But each chapter actually has a disease, something wrong. And you can tell your patient, hey, here's a physician out in New York that, I'd love for you to read the first 2 chapters so you understand what's going on. And then read chapter 25. It's about whatever the issue that you happen to have. And so that was really good. Shireen Lim, Lim, Shireen, Shareen, and has written a book about pediatrics. And it's like Breathe Well, Thrive, something to that effect. And I cannot come up with it. That was the one I was turning around because I can't come up with the title right offhand. So sorry about that. You just have to look it up. Shireen Lim. She's general dentist in Perth, Australia. How effective?
Is it Breathe, Sleep, Thrive? Is it that one?
That's it. That's the one. Breathe, Sleep, Thrive. I had 2 of them. So how effective? Oops, question went away. How effective are adult palatal expander type appliances like Vivos that are available to help increase airway? So I can't speak directly to Vivos. As a prosthodontist, unfortunately, I get sent a bunch of the cases that don't go well. So I don't know. I don't have a great numbers deal there. However, if I was recommending palatal expansion on an adult, I wouldn't do it that way. I would actually use a micro implant assisted rapid palatal expansion. It's called MARPI. And some of the new custom designs that have been out a few years now have not failed yet. So I know some failure will occur someday, and one probably happened right then when I was saying it. But they're incredibly effective at getting palatal expansion in adults. And it's not just pushing and hoping and tipping. I mean, this is literally breaking the sutures free and getting the expansion. So custom MARPIs is how I would go today with an adult. Next one is, after the elimination of the source of the erosion, how do you reduce the sensitivity on the teeth? Cover the teeth with full coverage crown. It depends on the amount of damage to the tooth, if it warrants. And I don't necessarily, I mean, If it warrants full coverage because of structural issues, then that's fine. I do have a lot of patients that have sort of ditched out the teeth, and I'm now doing a significant number of overlay. So you get a better look on the facial, and you overlay the occlusal surface. Downside, obviously, is you're bonding to eroded dentin. So your risk of debond goes up or fracture goes up somewhat, but a lot more conservative. And then finally, there's studies on just coating the tooth with adhesive. And so you go in at the hygiene visit and they put on some, your adhesive that you'd use to just your classic dentin adhesive, blow it thin and cure it. And it does a nice job of slowing down erosion as well. So, all right. When do you manage the transverse width from say 3 to 14 and expand laterally and deal in AP dimension? How do you manage the occlusion? The mandible constantly is adjusts itself to fit within the maxilla. That's its only purpose, is to fit. And when you look at studies on growth and development and when things become altered, the maxilla becomes altered earlier than the mandible. So if they're growing in the presence of an airway issue, the maxilla will constrict, and then the mandible follows after it. So it just adjusts itself to it. So to your question, when you expand out the maxilla, the mandible routinely fits in place. It is very rare. Now we have options if it's not going to fit in, and we go through it on the case with the patient, but that discussion comes up much more infrequently than you would ever imagine. I just don't, it's just not that big of a problem, even though you would think intuitively that it would. And what age can you do expansion? In the end, how does it all? So we're popping 60-year-olds open now. So I think the answer used to be that the suture actually fuses early on. That's what I was taught. But that's not true. Once cone beams came around, we figured out that it was more tortuous. So it's harder to break open, but it really doesn't fuse until the age of 70. So you can pop people open into their 60s easily. How do you get a reference position for reconstruction? I actually always start by expanding the lower first and rounding out the arch on the lower, so we know exactly where we're going, and then that becomes the reference in how we expand the upper. So always begin the process on the lower. Interventions or referrals can be done for patients at an early age, 3 years old. What interventions? Whatever interventions you would do at 7. I mean, and more, actually, some of them. We've got prefabricated stuff, and we've got traditional orthodontic appliances. The confusion always comes in. You go, well, my orthodontist doesn't treat until they're 7, 8, 9, whatever. It's not that the appliance won't work. The appliance absolutely works beautifully. In fact, it probably works better in a 2, 3, 4-year-old than it does even older, because they haven't had so much change that's occurred by then, and kids tend to be more compliant. The orthodontists are not trained to manage a 3, 4-year-old. They're trained to manage 7, 8, 9, 10, 12, all those kids. It's a management issue. It's not a technique issue. So the techniques are the same. How do you design an occlusal guard for patients with excess overjet or overbite with possible airway issues, but decline to sleep study? It's a great question. I think what you're highlighting is that class 2 patients are way further down the arc, and as you open them, you close off their airway pretty quickly. Typically on those patients, well, we have this thing called the Seattle protocol at Spear that we teach, which is to try to find the appropriate appliance. But if you want to make a guess, I'm going to use an anterior repositioning splint, and I'm going to move the lower jaw forward to hold it forward, not like a sleep appliance. I'm going to use a traditional TMD type of appliance there. We got somebody that loves the book. It's a good book. MARPI, MSC, SARPI Dome, yes, but they don't offer AP expansion. You actually, MARPI will, MSC, the studies that Juan Moon did show some AP change, a positive AP change, but how we address AP change on if we pop a maxilla free is we put bollard plates in the lower where the canines are, and we run constant pull elastics off of the maxilla. So it used to be that you would put the bollard plates in the upper and the lower, and the surgery on the upper was really difficult on patients, multiple pins, the bone isn't the greatest. So now we just put the plates in the lower, and when you pop them free on the MARPI, then just put the constant pull elastics in and bring them forward. So I think I answered that one, which was the next one. How do I do it? How do I decide MARPI or MMA? Actually, MMA is if the mandible has to be done, if I'm so deficient in the mandible. And I will say that we are promoting, although we haven't gotten huge compliance, but we're promoting doing MARPI on the maxilla of patients that are going to go through MMA. So they only have to have 1-piece maxillas rather than 3-piece maxillas. And so, or 2-piece maxillas. So we're always promoting MARPI and then go, okay, if MARPI doesn't work, you're set up for the MMA. Comment on Soma appliance by draw crew. I don't know anything about it. I don't know. It's Soma appliance. I don't know it. If it has the ability to calm the sympathetic nervous system, then that's cool. That's what I want. It's in order to do that, it has to get you to breathe through your nose somehow. So that's the key to calming the sympathetic nervous system. Do patients feel a difference with breathing? Yeah, when the palate's expanded, absolutely. That's the first thing out of their mouth. The moment it pops open, absolutely, like almost every single one of them, that's the first thing out of their mouth is, oh my gosh, I've never been able to breathe through my nose like this. So, all right, Jerry, I think I got them all done.
I think so. There were a couple in chat, didn't make it in to, there was a question about intramolar width. I said, what would be the normal intramolar width of the upper jaw
in
order to not have apnea?
there isn't a normal. Every orthodontist, everyone that talks about it has their own way of measuring. UPenn has one, McNamara has one. I mean, everyone has one. What I'm using now is the articles I showed out of the ENT group in Brazil actually measures off palatal bone. And so I'm using palatal bone measurements off cone beam, both at molar and premolar, first premolar. So out of that article.
Is there a reason you don't recommend SARPI for males since they aren't going to expand with MARPI?
They do expand with custom MARPI. Yes.
Also,
custom MARPI is my number one, and number two is either if they're not doing, let's say that they don't expand. Yes, I absolutely do SARPI or Dome, and Dome is what we've been doing for a long time, and we've had some surgeons, because you have to do virtual planning, they don't want to put their patients through the virtual planning, so they do SARPI, which is just a more aggressive surgery. So, but yeah, I absolutely do it. If I can't get a custom, then that's what we do.
They said also SFOT to address dentoalveolar components, I think.
Yeah, SFOT is great. I especially use it in the lower arch if I'm doing MARPE on the upper or any kind of procedure on the upper to expand it, SFOT on the lower is a great way to get maximum expansion of the lower arch.
Okay.
Right.
That's it. Those
Good
are all the
deal.
questions.
Thanks, guys. Hope to see
Thank
you
you,
out at
Dr.
Spear.
Rouse.